Evening all, and I will this evening I'll speak to you on biomarkers in non-small cell lung carcinoma, and you will all agree that biomarker-directed therapy. Find a contact name cell line. Biomarker-directed therapy in non-small cell carcinoma has been a poster child of genome-directed therapy, and as General Kapoor said, that rapid strides have been made in this arena of biomarker-directed therapy in non-small cell lung carcinoma in the last 5 years. So today, compared to the 5 years back, we are identifying 9% additional cases of non-small cell lung carcinoma with an oncogenic driver. We have 5 additional biomarker-directed therapies in first line for metaxon 14 skipping mutation, for ROS1 fusion, for BRAF V600E, RET fusion rearrangement, and anti-RK fusion rearrangement. And we also have 2 new second-line approvals for KRAS G12C and EGFR exon 20 insertion mutations. We are also seeing newer drugs being developed for established biomarker to overcome the acquired resistance so that we can prolong the survival. And biomarker, because of the confidence that oncophysicians have developed in the biomarker-directed therapy, they are now willing to use targeted therapy or genome-directed therapy with level 2 evidence, for example, in the uncommon EGFR mutations, as well as in the HER2 oncogenic mutations. And the genome-directed therapy, as you will all probably know, that has already insinuated itself into the adjuvant setting. So osimertinib is approved for usage in resected lung cancer with EGFR mutation in stage 1B to 3A. And this phenomenon is likely to expand further for other biomarkers as well as for neoadjuvant treatment. So there is an ALINA trial, which is already an ongoing phase 3 trial looking at use of alectinib in a similar situations as osimertinib in resected lung cancers of 1B to 3A stage. And there is this great trial from Lung Cancer Mutation Consortium, an umbrella trial, looking for 11 actionable drivers in lung cancer and treat them with a matching drug in a new adjuvant setting. Another Nautica trial, again looking at several of these biomarkers in lung cancer to treat them with a cognate kinase inhibitor in both neoadjuvant as well as adjuvant settings. And if these trials have to prove successful, they will herald testing for biomarkers in all non-small cell lung carcinomas across all stages. So so why is this great fancy for biomarker-directed therapy or targeted therapy? It's because the targeted therapy improves overall survival. So in early days, way back in 2014, it was shown that this survival with targeted therapy can be enhanced by 1.1 years. So against 2.4 years with chemotherapy, one could achieve 3.5 years of median survival with targeted therapy. In this French national trial, it was shown that those who have gene alterations had 5 months survival advantage compared to those who lacked a gene alteration. And in this study, however, this was way back in 2016, there were many of these genetic alterations which were not actionable at that time. And as we are seeing many of these registration trials, which started 4 years, 5 years, 6 years back coming to fruition, we see now that in EGFR mutated lung cancer treated with osimertinib, one can achieve an OS of 38.6 months. For ALK rearranged tumor, it's around more than 46 months. Actually, as a matter of fact, 57% patients survive at 4 years using crizotinib. And if one can sequence crizotinib with other second and third generation ALK inhibitors, in this study from Colorado, overall survival of 86 months was achieved. So the current doctrine is because of these great benefits in overall survival, to treat as many patients as possible with genome-directed therapy. So what kind of genome-directed therapy we are speaking of? So we look at the various guidelines, where the NCCN guidelines, the ESMO guidelines, or the ESCO guidelines. There are 8 genetic or 8 biomarkers or 8 genes in which the alterations are actionable currently. 4 of them are well established: EGFR, L fusion, ROS1 fusion, and BRAF V600E. But there are 4 new additions. So there are 4 more alterations which have become recently actionable. For example, RET fusion rearrangement, MET-exon 14 skipping mutation, NTRK fusion, KRAS G12C, and also, as I said earlier, many oncophysicians are willing to treat uncommon EGFR mutations and HER2 oncogenic mutations with gene-directed therapies. And another development that has happened is that earlier we were enriching the population that we will test in squamous cell carcinoma, but today the NCCN guideline says that consider molecular testing in squamous cell carcinoma for all cases, because 10.5% of lung squamous carcinoma have actionable alterations. So with this information, there are 3 questions that crop up in the mind. The first question is, how many biomarkers should be tested? What should be the method of testing? And what should be the order of testing? Shall we test sequentially, or shall we do broad molecular testing upfront, or can we actually mix and get the best of both worlds? And this must be done with the constraint that the tissue available is limited, and we have a limit of a reasonable turnaround time. So how many biomarkers should be tested? So as the new biomarkers are emerging and the treatments, the corresponding treatments are being checked out, it is seen that capmatinib in MET-exon 14 skipping mutation, entrectinib in NTRK fusions, and selpercatinib in RET fusion, they all improve objective response rates and durations of response and median progression-free survivals. And same will apply to tepotinib, larotrectinib, and pralsetinib. And it has also been seen that even in HER2 oncogenic mutations, where the patient has become refractory to chemotherapy, the use of trastuzumab deruxtecan can provide duration of response of 9.3 months and overall survival of 17.8 months. So the benefit, even with these newer biomarkers, is substantial. So if we place these benefits, if we check how these benefits are placed vis-a-vis the tyrosine kinase in use already, so we will see that capmatinib, entrectinib, selpercatinib, and pralsetinib provide an objective response rate and a median progression of survival somewhere between the first and second generation of TKI for EGFR and ALK, and the best response-producing TKI for ALK, ROS, as well as EGFR, somewhere intermediate to that. And as far as the sotorasib and adagrasib is concerned for KRAS G12C, the objective responses and the progression-free survival matches the second generation ALK and EGFR TKI, and TDX can match in HER2 oncogenic mutation the first generation of TKI for EGFR. So the benefit is substantial, and therefore the corollary from that is that we need to test all patients of NSCLC, advanced lung adenocarcinoma, for these biomarkers. So what are the various methods available to us? So we can do fluorescence in situ hybridization. The fluorescent in situ hybridization can be done for ALK, ROS1, RET, and NTRK. We can use immunohistochemistry for ALK rearrangement, ROS1 rearrangement. However, the ROS1 rearrangement, this is a screening tool, Any case which is found positive will have to be further tested. And BRAF V600E, the antibody is good and can be used. IHC can be used for detection of BRAF V600E. And then one can use PCR for amplification with fragment sizing to detect MET exon 14 skipping mutation. RT-PCR in the form of amplification refractory mutation system or peptide nucleic acid clamp has been used for EGFR mutation, BRAF V600E, and HER2 oncogenic mutations. But remember that instead of doing all of this, one can actually use next generation sequencing and find all these alterations in one single experiment. But that brings into question the fact, is next generation sequencing really a validated method? So this was an early study. This was done on 1,343 cases, which used next generation sequencing to look for single nucleotide variant. It was not to do 360-degree of genomic interrogation, but what was found was that at least for single nucleotide variant, the next generation sequencing outperforms the single gene assays. And the author said that this is a proof of concept that targeted and next generation sequencing can be used for routine and extensive screening at a reasonable cost. And then this is another very large French National Cancer Institute funded program. Multiple sites were used. 17,000 plus cases were tested by next generation sequencing. And it was found that the genetic alterations were recorded in 50% of the cases. The next generation sequencing failed in 1 to 4% of the cases in different centers. And this information that was gained by this NGS actually was useful in making therapeutic decisions in 51% of the cases. However, the limit of this study was that there was no orthogonal testing. One really can't say how many cases were false positive or false negative. What is the sensitivity and specificity? And we, in our own modest way, did this validation study on 86 cases, where we tested for 29 genes by next generation sequencing and also by single gene assays. And we found that the sensitivity of the next generation sequencing was around 90%, specificity was 100%, and the kappa score was 92%. And in addition, if we actually look at the companion diagnostics that have been approved by Food and Drug Authority of USA, you will realize that for every genetic alteration, every biomarker, at least one NGS platform has been approved. And for ROS1, BRAF V600E, NTRK fusions, and RAD fusion, actually only next generation sequencing platforms have been approved. So that means that next generation sequencing is the most smart platform for testing several biomarkers together. So if we compare the single gene assays with the next generation sequencing, the single gene assays, at least for the initial biomarker testing, will have a rapid turnaround time. However, single gene assays are not tissue proficient. And if you will do it sequentially, probably as far as the more frequent ones are concerned, the turnaround time will be well contained. But if you do for the less frequent, then turnaround time is likely to be breached. And one will need too many testing platforms and separately trained human resources. And for those cases where the initial testing does not yield an informative result, the cost is likely to be unfavorable. In contrast, if one has to use next generation sequencing, it's highly tissue proficient. You can interrogate the genomic alterations for single nucleotide variant, multi-nucleotide variant, fusions, insertion deletions, and copy number alterations. So you can actually look at the genetic alterations in 360-degree. You can also find novel mutations by NGS, which you won't be using single gene assays. You can gather information on co-occurring mutations and how do they actually affect the response to the coagulate kinase inhibitor. One can also find uncommon EGFR mutations, including exon 20 insertions not detected by PCR. And please remember that the PCR-based test detect only 50% of the exon 20 insertions. In other words, they miss about 5% of the mutations which reside in the exon 20.
And then, sir, you are just left with 1 minute to conclude.
Yeah, I'm finishing. So the next is that the turnaround time is unfavorable, especially for moribund patients. But in case we can actually increase the uptake of the next generation sequencing, and we can train our workforce better, we can overcome this problem of turnaround time. The cost currently is little high, but with the falling cost, it is likely to become less expensive. Another advantage of next generation sequencing is that one gets a readout of the mutation frequencies, and one can identify the mutations, low frequency variants, because the limit of detection is much lower. The problems are the penetration, the availability of the manpower and resources, and lack of enunciated minimal quality standards. So now how do we combine and get the best of the both worlds? So this is what we do in our laboratory. This is our real life workflow. So in a lab one, we do the histopathological diagnosis, select cases of adenocarcinoma, non-small cell carcinoma, NOS, and non-small cell carcinoma, fever adenocarcinoma. And we take around 25 sections, 5 sections we use for ALK, ROS, and PD-L1. And from 20 sections, we extract DNA, carry out amplification refractory mutation system testing for EGFR, retain this extracted DNA. If we find a mutation here, it's fine. If we don't, we take another 10 sections, find out, extract the RNA, and then using this RNA and DNA, we carry out the next generation sequencing. And in case the tissue is not available, we use plasma for EGFR by COBAS. If this fails, then we do the liquid biopsy for all other markers by next generation sequencing. And with that, I will, because I finished with my time, I will come to the conclusion. And my conclusions will be, because of the highly effective targeted therapies and the little likelihood of benefit from immune checkpoint inhibitors in those who have a genetic alteration, this testing should be offered to all patients with advanced non-squamous NSCLC, and preferably also all squamous cell carcinoma. And in cases of where metaxon 14 skipping and BRAF is suspected, all histologists must always be tested. Additional drugs are likely to be approved in the not too distant future for HER2 and EGFR exon 20 insertion in first line, and therefore one shall be prepared to test them upfront. And broad testing with NGS for both established and emerging biomarker is recommended. For pathologists, I will say, do the histologic subtyping using minimum number of sections and using just 2 IHCs. One can use primary tumor or metastatic lesions. It doesn't matter. Bone biopsy should be avoided, and liquid biopsy is always an option when tissue is not available. And with that, I will thank you all for your listening. I hope I haven't overshot the time too much. Thank you so much.
Thank you very much, Dr. Anurag. It's always a pleasure to listen to you. You make the difficult topic very, very simple, and it's very clear that yes, one should go in for NGS in all the metastatic and advanced non-small cell lung cancer because of lot of targeted therapy which has come, and
can I ask?
It has in fact improved the survival and the longevity. Yeah, Dubey, you have some question?
Anurag sir, with the permission of Kapoor sir, I would like to ask sir, like PD-L1 results, can we interchange for the drugs? Like if suppose 22C3, like what is my thing for asking this, that what are the concordance rates for the PD-L1 results by different platforms? Like if I get 22C3, if I am having high PD-L1, can I use another drug for which another platform has been approved, like SP1424 atezolizumab? But if patient is having 22C3 high, so It's not interchangeable.
You can't use cross-platform. You can use cross-platforms, but what you have to do is you have to do what is called fit-for-purpose testing. So on your platform with your IHC, you have to validate your results with 20 cases tested on the approved platform and bring the concordance, and then this will become fit for purpose usage. So this is a difficult task to do, but for each institution that wants to use one antibody and one platform, it will have to do what is called fit for purpose testing before you use cross platforms.
Okay. Otherwise,
and cross clones and cross clones.
Okay, sir. And secondly, sir, like recently the guidelines have recommended this biomarker testing for squamous cell carcinoma also. So what is your experience that how much, how many percentage of patients you are finding these driver mutations in them?
So, you know, like till very recently, I think till about 6-8 months, this was only being offered to patients who are young, non-smoker. You know, the NCCN recommendations were to test only in this enriched population. So, but we still found ALK rearrangement in 3 or 4 cases. We found MET exon 14 skipping mutation in 3 cases. We found BRAF in 2 cases. And I'm not so sure about EGFR because EGFR story ends quite many times with a single gene assay. But I'm pretty sure some EGFRs have also been found.
I've got, sir, one EGFR positive, sir, exon 19 in one squamous cell. That is the only one driver mutation in my small practice.
We do because you know, now in this paper, which is a wonderful paper, the NCCN has also alluded to that paper. So 10.5% cases of small cell carcinoma detected on biopsy. It's another matter probably if there was a resection specimen available, they may have had adenocarcinoma in some location. Okay. We don't know. But on a small biopsy, they were pure squamous carcinoma, and 10.5% of them had actionable mutation.
Sometimes it is adenosquamous carcinoma.
So we don't on a small biopsy.
Yeah, thank you very much, Dr. Anurag. And
thank you.